Hello. Thank you for selecting this presentation on the interdisciplinary care for survivors of female genital mutilation/cutting, henceforth referred to as FGMC. My name is Jessica, the primary contact for this poster, and I am pleased to discuss the state of FGMC knowledge and care among medical professionals in the United States. FGMC is a common, albeit controversial, traditional rite of passage in several parts of Southeast Asia, Sub-Saharan Africa, and the Middle East. In its most traditional form, it is conducted by traditional cutters or local barbers without using anesthesia. It comprises multiple forms of injury to the female genitalia for non-therapeutic purposes. The practice's invasive and often graphic nature breeds a culture of shame and silence regarding the female's experience, making incidence and prevalence rates subject to underreporting. However, data reports that every 11 seconds, a girl experiences genital cutting, often against her will. Over 200 million women have experienced FGMC today. With increased global migration, the United States has become home to women who live with the physical and psychological consequences of traditional genital cutting. For this reason, multiple disciplines of medicine must be equipped with an awareness of the practice and its implications for patients in their field. In Figure 1, we see 3 of the 4 types of FGMC. According to classifications provided by the World Health Organization and the National FGMC Center in the United Kingdom, Type 1 involves partial or total removal of the clitoris. It is also known as a clitoridectomy. This type was also prevalent in the United States in the 1940s and 50s when doctors used it as a prescription for a wide range of so-called ailments, including masturbation, lesbianism, and hysteria, among others. It is important to note that while this is no longer the practice, FGMC has its place in United States history. Type 2, or excision, involves the partial or total removal of the clitoris and the inner labia. Type 3, or infibulation, involves the narrowing of the vaginal opening by creating a covering seal. In the process of narrowing the vaginal opening, the seal covers the urethra, that is, where urine is released from the body. Type 4, not pictured here, involves all other harmful procedures to the female genitalia for non-medical purposes, including but not limited to cauterization, piercing, pricking, and scraping. The differences in each type have implications for multiple fields of medicine, prompting the first objective of this study. Here we aim to highlight the implications of FGMC in multiple disciplines, including urology, pediatrics, gynecology, obstetrics, psychology, and neurobiology. Since the United States has become home to at least 500,000 survivors and women, Since the United States has become home to at least 500,000 survivors and women at risk, the second objective focuses on the current knowledge, attitudes, and care capacity of health professionals in the United States. This was conducted using a scoping review. In this section, we ask the questions listed on the left side of the poster. Our selection process is detailed in Figure 2. Please feel free to pause the recording and zoom in at this point. I will highlight a few of the disciplines included in our table. The field of surgery is most implicated when dealing with type 3 or infibulation. In this case, a pregnant woman may choose to be de-infibulated or reopened to allow her give birth through the vaginal canal. There have been cases in the United States where the woman gives birth and asks to be re-infibulated. This is the process of returning the genitals to the sealed state it was in prior to childbirth. Additionally, some surgeons offer clitoral reconstruction, focusing on portions of the clitoris that may be found under scar tissue. According to an article by Penn Medicine in the United States, reconstruction reveals the clitoris and attempts to, quote, restore and rebuild affected anatomy. This is performed using techniques developed in parts of Europe and North America. Gynecology and obstetrics, 2 fields often discussed as one, report the highest knowledge of FGMC in the United States. Here we find that stitching the labia majora can inhibit the free flow of menstrual blood, creating complications in the uterus. Additionally, as discussed in a 1995 book by Efua Dorkeno, the traditional operator's poor hand-eye coordination can damage other organs and blood vessels, leading to excessive hemorrhage. Finally, severe postpartum pain and chronic pelvic pain have been reported to be higher in survivors of FGMC than those who have not experienced the procedure. The field of urology is one of the least studied in terms of FGMC, or surviving FGMC. However, bladder infections and kidney stones have been reported in FGMC cases where the urethral opening has been covered by a stitched labia majora. Blood clots, swelling, or sutures create obstructions to the passage of urine, consequently leading to frequent urinary tract infections, or UTIs. Excessive urine retention due to pain or the fear of pain is also common. Moving on to psychology, anxiety before the cut, terror amid the process, and the shame of violation all constitute the psychological trauma of FGMC. These feelings are, however, often juxtaposed with the atmosphere of celebration within the community, as the girl has now begun her journey into womanhood and marriageability. In some communities, the female child is raised to understand her genitalia as, quote, dirty, implying a need for cleansing. In others, it is seen as a source of irresistible temptation, encouraging a system of victim blaming built against the abused. This also has implications for the field of pediatrics. Consequently, a mental conflict between violation and social acceptance is created. Without the help of a psychologist or a psychiatrist, many can suffer muscle spasms as a side effect of unresolved mental anguish. In other cases, the lack of sensation during intercourse can leave the female feeling numb or used, even in a loving, consensual relationship. Last, and certainly not least, is the field of neurobiology. The central nervous system records FGMC trauma much like it does for other traumatic experiences. That is, it affects innervation, also defined as the supply of nerves, energy, or stimulation to a part of the body. A 2008 study by Gilliam Einstein explored the effects of FGMC on the vulva, pelvic viscera, spinal cord, and brain. The brain and spinal cord respond to amputations by rearranging neural pathways or networks. This, in turn, would affect neural signaling to target structures and modify sensory perception. It is important to note that the vulva is one of the most highly innervated parts of the human body. All types of FGMC can affect neural innervation. Aim 2 of our scoping review, or of our study, is abbreviated to the right side of the poster. There's little to no knowledge of the culture and traditional implications of FGMC among health professionals in the United States. The amount reported to receive training ranged from 5 to 80%. However, 80% in this case is the anomaly, as the next percentage below 80 in this review was about 23%. Only one study actually reported 80%, and this was among health professionals who already serve an immigrant population of FGMC survivors. A range of 21 to 53% of health professionals reported feeling comfortable with speaking about FGMC to patients, and only 13 to 23% felt prepared to provide care. Finally, ethical conflicts reported were focused on the nuances around reinfibulation, violation of reproductive rights, and a fear of breaking the law, as it is currently illegal to perform any form of FGM in the United States. Limitations of this study are primarily around Aim 2, where more recommendations and ethical implications could have been missed by excluding studies outside of the United States. Thank you so much for your time. This research is currently in its manuscript development stage. Due to a lack in space in the poster, references are available upon request.